Good morning or good afternoon. First of all, let me thank the organizers of this important conference. I'd also like to thank our colleagues at the Malawi National AIDS Commission and Georgetown University for organizing this panel. I'm Tyler Smith, the co-founder and chief technical officer for Cooper Smith. We've had the great fortune of working hand in hand with HIV providers, policymakers, and funders in Malawi for several years now. And we're really excited to be the lead data partner for the Blantyre Prevention Strategy. By now, hopefully you have a better sense of how the strategy intends to be different from past prevention efforts. This lens on innovation very much extends to our data approach as well. And so today I'll walk you through our plans to develop a multi-sectoral data pipeline that we hope will not only optimize data use, but also prevention services in the district. As we were gearing up for this engagement over the past year plus, we really took stock of all the information that is at our disposal to inform HIV prevention programming, both in the district and at the national level. We found these data to be lacking. Traditional data sources do little to help us evolve our understanding of HIV acquisition risk or prevention performance writ large. And we really argue we need a new paradigm for thinking about which information is most relevant and most useful for targeting services and driving down incidence. And there's a couple of primary reasons why we think we need this new paradigm. The first is that the lens we typically have is too narrow. So when you think about it, the people that we are trying to identify and provide support to have incredibly complex lives, and only a small fraction of their time is spent engaging with the formal health sector. When we do have a touch point with them, their experience is usually reduced only down to a few data points, things like age, sex, home location, if we're lucky, diagnostic result, and treatment. And we know that social determinants of health, such as socioeconomic status, education, food security, account for as much as half of health outcomes. And certainly these will play a role in HIV acquisition. I think we do a fairly good job of thinking about designing prevention programs so that we incorporate these other facets and more pervasive facets of individuals' lived experience. But we don't do a really good job of understanding data that comes from other sectors that would help us to better potentially predict new infections or respond really quickly when situational factors might influence upticks in incidence. So I see this as a major missed opportunity given the wealth of data that's already existing in a country like Malawi. The second reason we need a new paradigm is that the systems and processes that we have for data use now are overly fragmented. And I know that anyone who works with HIV data will commiserate with me on this point, but I've tried to illustrate some of the complexity of the data ecosystem at country level in this diagram. From the point of origination, point of care for information, to the user or actor who intends to take that information and do something with it. There's multiple steps and processes and functions that must happen in a country like Malawi. And this includes collection on paper-based forms, digitization of that information. There's usually some sort of transformation process. Obviously, it must be stored somewhere. There's manipulation or analytics that need to take place on those data. There's various ways the data can be accessed by users, and then there's tools that allow you to visualize and report this information. And so when you think about any one particular use case that you're interested in, so generating an insight for an actor who is trying to make a decision or take an action, you might end up with an information pathway that looks something like this. So data come from multiple different sources. They're transformed in different ways. They're stored in different places. They're manipulated in different ways and accessed through different points. Similarly, for another use case, you might see an equally convoluted pathway but slightly different in the tools and processes that those data must go through in order to be useful. And then we can continue to draw lines here for yet another use case. And I think the important thing to keep in mind is that many of these steps, these components of the data ecosystem are similar. And so there's a lot of opportunity for us to rationalize this process and create quicker, more efficient data pools that really respond to users' needs much more appropriately. So how are we planning to streamline these processes into an optimized HIV prevention data pipeline? I think the first thing is that we're not going to get tripped up in the complexity of the country ecosystem and take a supply side approach to trying to streamline and rationalize. We've really flipped the model around to focus on the user first. So all of the software, the data support that's provided through BPS will be user driven, meaning that every activity that we undertake must be linked to a country developed use case and in service of that use case. Here's an example of what we mean by use case. There are two user stories we've included here. Through the formative work for BPS and the ongoing engagement with stakeholders at all levels, we've been able to develop this core set of use cases that are priority for HIV prevention. These include how information would be optimally used to act most effectively and at the right time. And so in the first example, the top tile, you can see that we have a Blantyre city councilor, and she's able to access information on population movement in and out of the city during rainy season. She is further able to identify venues that have been mapped for high-risk HIV behavior and compare the areas where we expect to have those population movements with the high-risk venues. The idea is she can then take this information to allocate resources or mobilize partners to mitigate that risk at the right moment in time. In the second tile below, we have an STI clinic nurse, and she's able to layer data from STI testing and diagnosis spikes with outreach activities in the community. And here we're trying to understand which mobilization activities result in the highest yield of high-risk individuals that are coming to clinic. Once we've documented all of these use cases, our goal is to allow the information to flow as efficiently as possible. And so we began to think of the streamlining efforts really as an information value chain and trying to group those various components into key functions along this chain and figure out where we can consolidate steps, combine common processes, and return insights much faster. Obviously, prioritization will be key here and country stakeholder driven. It's also important to highlight that almost all of this incredibly complex digital architecture, analytics, and processes will be developed and maintained by Malawian nationals working as part of the Malawian Ministry of Health. We've been committed to real and measurable technical capacity development since our first day in country, and the BPS work will enable further strengthening of this digital health cadre and put the government in control of core systems and components of the data pipeline. The good news is, in terms of sustainability, we have a lot to work with in Malawi. Some time ago, Malawi adopted the Open HIE digital framework. This is really an organizing principle for a coherent enterprise architecture for digital health. All of the items within the framework are shown here in this diagram. Those highlighted in green are fully functional and operational in Malawi, with the remaining components either in development or planned. All of the additional tools, support, software, analytics will be leveraging and built upon this core underlying architecture in Malawi. And finally, I would like to talk a little bit about the comprehensive monitoring system we've put in place that we also feel is pretty novel and will be largely fed by this prevention data pipeline. We're calling it the Prevention Adaptive Learning and Management System. The idea is both the learning and metrics that we're using are adapting, as well as the management that results from them. There's two core functions of this, one being an internal facing side and the other an external facing side. For the internal, we're really focused on transparency and accountability for the work that we're undertaking within BPS, and ensuring that progress is happening as intended and that those elements of support are performing the way that we would hope. For the external side, it's really meant to focus more on prevention performance in the district writ large. So thinking about all of the information we have at our disposal for programmatic activities, key prevention performance metrics, modeled estimates of incidents and coverage, et cetera, and taking all of that into one comprehensive and easy to digest set of information everyone is able to look at, all the key stakeholders can take into their communities of practice or into their management meetings, and really be speaking a common data language when they're making strategic choices. Finally, there's this schematic which outlines how we envision the PALMs to work. So you can see the BPS consortium partners along the bottom here. We have our investment priorities, which are largely driven by the government. We have our BPS activities that we're undertaking, and then our progress indicators, which is that internal side to let us know that that's all happening as intended. Above, we have kind of the full set of all other HIV prevention stakeholders. They have their own investment priorities, and that translates into HIV prevention activities and services deployed. Our goal is that data taken from their activities, as well as merged with all the data from the BPS work, will come together in that external facing data set, which we're calling key prevention performance indicators. And that information would then be easily accessible by the full set of stakeholders and hopefully inform investment priorities as well as HIV prevention activities in a very iterative and frequent fashion. And finally, we are working on developing a core set of sustainability indicators that will help us to understand how likely all of these systems are to persist into the future. So thank you very much for your time. We're really excited about taking on these substantial challenges and would love to hear your thoughts or feedback. So let us know. Please take care of yourself during this unprecedented and challenging time in history. Thank you very much.